So inevitably, when you're doing an ACDF, you're trying to get to the nerves from the front and the disc is in your way. So you're going to do the majority, probably 90% of your work already is going to be done by the time you get back there. And the nice thing though is the reason Neuralytix has a benefit is that once you've taken the soft tissue part of the disc out before you've done any bony work, that's the first chance you're going to get to test the nerve. Because I bet a lot of times we do more work than is necessary in an ACDF. And by that time, you've also elevated the intervertebral height. So you've got your Caspar pins in. And so my first point of testing is once I've taken the soft tissue part of the disc out, I've taken the posterior longitudinal ligament out, and I'm looking at just a narrow corridor between the uncinnates back to the actual dura of the spinal cord. And right where the uncinnates round up, so right as it kind of runs up, I go straight back from there and I touch the spinal cord at that point. And that's where the motor rootlets come off and then go out and exit to connect with the dorsal sensory rootlets to make a dorsal root ganglion and a nerve root. So pretty medial when you're doing an anterior cervical discectomy for disc arthroplasty or for fusion. So at that point, if you're stimming normal, it probably means that you've elevated the height enough and you've taken out the disc bulge that was offending the motor units of the nerve root, and you can instrument the neck and be done. Especially with the Woodson style probe or the hockey stick probe, you can easily, it's so thin, you can slide it under the uncinate if you need to get more contact with those motor rootlets, or sweep it up under the vertebra where they're coming off. The rootlets, if you look at the anatomy, they're coming off like this, and they kind of coalesce to make the motor unit of the nerve before it connects to the sensory unit. And so it's a pretty wide area. I sometimes will put it straight back or even rotate it just under the back of the vertebra or slightly under the uncinate to try and get the best spot. But I'm testing multiple spots. If I get a 6 right when I go straight back, I go under a little, I go up a little, and I try and get that as low as possible. And you just do it on targeting, and it's going to be wherever you move it, it's constantly capturing data. So you know whether you're getting, hotter or colder, as they say, to the right number based on where you're moving it slowly. Straight back from right where the uncus starts to round up, starts to round cephalad. So straight back on the, like if I'm doing a C4-5 and you've got 2 end plates here, on the C5 end plate, straight back from where it starts to round up. It's called the uncovertebral joint or the uncinate as it starts to create that smiley face. Straight back from there is where I start. If I can't get a good reading, then I'll go under the uncovertebral joint, kind of more closer to the foramen, and then I'll go a little bit up under the cephalad vertebra as my third point. And then if I've gone all 3 of those areas and I'm still getting a 6, I know for sure I need to decompress that nerve. So then I take my Kerrison, I'll work laterally like we all would, and I'll expand that foramen. I may even elevate the disc height a little more with the distractor device, and then take my retractor and open it up to hold it and retest after I've done a little bit of work. And then if it's still abnormal, I'll keep going. So that's the nice thing about it, is it's going to tell me when I'm done or when I'm not done. Now, if it gets to the point where you've already gone as far and as wide as you feel comfortable and it's still testing high, like you have to stop at some point. But yeah, that's how I would initially test. The majority of the time you're going to get a 2. You can get 1, you can get 1.8, you can get, your system is much more specific than some other systems. And so you're typically going to get like between 1.4 and 2.8, something like that. Same place, although you have access now to a little farther out on the motor unit as all of those little rootlets come together to form one nerve. So if you can get more lateral, you may get more accurate stimulation, but it's not necessarily true. I try and go back to the same exact spot, so I'm getting apples to apples comparison, my pre-op or my pre-decompression to my post-decompression reading. And if I'm still not getting it, I'll move the probe around slowly and see if I'm getting a lower reading. But